We ended the last module talking about stroke volume and how it is affected. And now we're going to go through each of the ways that stroke volume can be regulated during exercise. So what I have here is just, again, the slide from yesterday for a brief review, but stroke volume is mainly regulated by three factors. One, end diastolic volume or preload. This is the volume of blood in the ventricles at the end of relaxation, right before it gets able to contract. Second, although we have a number 3 here, apologize for that, is the strength of the contraction, right? We can increase contractility. And then last but not least, the mean arterial pressure that the heart has to work against. And this is the inverse relationship. So if pressure goes up, blood flow goes, or stroke volume goes down. So let's break down each of these three and look at how they are. So what happens to venous return? During exercise, we get a very large increase in venous return. And that is for 3 reasons, right? We have 3 mechanisms by which we get more blood back into the heart. So one is we can get venoconstriction. Not a lot, but a little. So unlike our arteries and our arterioles, which can contract and relax, vasodilate and vasoconstrict to very large degrees, our veins much less so. But since they contain so much blood, they contain about 65% of the blood volume, even slight constriction due to the sympathetic nervous system will cause an increase in blood. However, it's not that effective in skeletal muscle because our skeletal muscle is going to override this sympathetic nervous stimulation, which we'll talk about. So that's one. We can squeeze blood from the veins back to the heart. Second is we have what's known as the respiratory pump. The respiratory pump just goes back to the old school basics of blood flow will occur from areas of high pressure to areas of low pressure. So as we breathe, what happens is during inspiration, our intrathoracic or upper chest level pressure increases. As we expire or breathe out, that pressure decreases. The exact opposite happens in our abdominal cavity. So during inspiration, our abdominal cavity relaxes. During expiration, it increases. Right? So what that does is it creates an altering between contract or increases in pressure and areas of low pressure. When it does that, blood will always move back to the heart during those intervals, right? So as the intrathoracic pressure decreases, the abdominal pressure is very high, which will pump blood back up to the heart and increase the amount of blood flow getting back, thereby increasing preload. So while both of these work, I would say they're minimally effective, right? The third mechanism is the primary way that we get a lot of blood flow back as far as exercise is concerned, and that's what's known as the muscle pump. This is the same idea that we have this going from high pressure to low pressure. We have rhythmic muscle contractions that propel blood to the heart through one-way veins. So let's look at them. Here's a really nice picture from the textbook, which I think illustrates this very nicely. So the heart, our veins here have these valves that only allow blood flow to go back to the heart. We can't have blood going back. So as we squeeze our muscle, what's going to happen is we're going to generate pressure. Since blood is mostly water, which is an incompressible liquid, when we squeeze, it's going to try to go down, but since that's closed off, then it will be squeezed back to the heart. And you can see that's exactly the case. And while we try to get a little bit going back here, right, that goes nowhere. So the majority of the blood goes back to the heart and squeezing that. This is best to be thought of as kind of like a milking action is what it's described by the book. And I think that makes perfect sense, is that we squeeze blood and it goes back to the heart that way. So those are the 3 mechanisms by which preload is increased. Again, getting more blood in to the heart allows it to contract more. So if next we look at contractility, we can see that both of the mechanisms that we talked about yesterday apply. So one, we get an increased preload, which is known as the Frank-Starling mechanism, which means an increase in stretch which means increased cross-bridge formation, which means stronger contraction. And again, that's the green curve here. A greater end diastolic volume or preload, and we get an increased stretch. As we've talked about several times, we also get an increase in the sympathetic nervous system. With that, we increase contractility alone. So ultimately what happens is we get both an increase in the Frank-Starling mechanism and an increase in sympathetic nervous system to increase contractility in the heart. So what about afterload? Right? So again, to talk about afterload, what we're really talking about is mean arterial pressure, right? Blood pressure, the average blood pressure in the heart. So again, to eject blood, we have to generate enough pressure by the left ventricle to exceed the pressure in the aorta. And therefore, as we've talked about, it's a barrier to an ejection, and thus stroke volume is inversely related to aortic pressure. Exercise can try to minimize this, but what do we actually look for in blood pressure? If we take a look at the factors that are going to influence arterial blood pressure, we have two. So first we have cardiac output. We've already talked about it. This increases with exercise to meet metabolic demand, and it increases linearly. Second, we have the second factor is total peripheral vascular resistance. We talked about this very briefly yesterday, but this is the sum of the resistance of all of the systemic blood vessels. So if we think about that, then our mean arterial pressure is equal to our cardiac output times our total peripheral vascular resistance. And an increase in cardiac output or vascular resistance is going to increase a mean and arterial blood pressure. So we'll focus on that in the next video. Before we clear out though, I want to circle back and give a really quick refresher, right? So we looked at heart rate, stroke volume, and cardiac output. Heart rate increases linearly. Stroke volume increases to about 40% of VO2 max and then doesn't increase anymore after exercise as exercise intensity increases, right? Cardiac output increases to 40% of VO2 max very sharply and then less so, right? If you draw a line down the middle of this isn't the best line, but what you'll see is, of course, this inflection point in cardiac output is due to the stroke volume inflection point, right? So we can summarize this by saying the increase in cardiac output up to about 40% of VO2 max is due to an increase in heart rate and an increase in stroke volume. After 40%, the increase in cardiac output is due only to increase in heart rate. There is no increase in stroke volume, so heart rate is solely responsible for the increase in cardiac output from 40% of VO2 max all the way to maximal exercise. So one situation that I'll point out that this comes together is that a change in maximal cardiac output with aging. So why does cardiac output decrease with age? It increases in a linear fashion after about age 30, and it's primarily due to a decrease in maximal heart rate. Most of you guys should be familiar with estimating maximal heart rate is 220 minus your age, right? So therefore, as you get older, your maximal heart rate will decrease. And therefore, if your maximal heart rate decreases, it plays such an important role, in fact, the only role of increasing cardiac output at maximal exercise intensities, we also have a decrease in maximal cardiac output, right? So that's a reason why 40 and 50-year-old men aren't winning marathons or winning these long-duration exercise stuff, is because they don't have the cardiac output to meet that metabolic demand. Okay, so that ends this lesson. As we finish this, we'll jump back into blood pressure and blood flow in the next video.